Let me introduce myself first. Okay, I'm Dr. Sandhya. I have basically done my FNB in maternal fetal medicine and currently practicing as assistant professor in maternal fetal medicine department. So, the topic which I chose specifically today for class is about antenatal steroids, and I want all of you to be very free. Any questions, please type in the chat box. Okay, and we'll try to address all your queries. So why this topic? See, I don't know how many of you are all are post PG or post MBBS. So what I was taught in my PG is, what is steroid? Okay, any patient before 37 weeks, give off steroid. That's all. We never used to think anything. Patient 35 plus 6 weeks in labor with leaking, little bit pain, give steroid. That was the main dictum which was taught to us. But now everything is changed. You can't just give steroid left and right. And that is why I've chosen this topic. I want you to understand what steroid does and why we are so cautious about giving steroids. Okay? And please be mindful after discussion. I would be very happy if you have an open discussion. You can put on your videos and you can ask whatever you all want. Okay? So let's start with basics. If we talk about respiratory system, we all know that we have a trachea which divides into primary, secondary, tertiary bronchi, which will further give rise to bronchioles, these terminal bronchioles, and these terminal bronchioles is going to give rise to respiratory bronchiole, which will further divide into alveolar duct and an alveolar sac. The part which I have put in blue color is the conducting part of our respiratory system. And these three parts, the respiratory bronchiole, the alveolar duct, and the alveolar sac, which I have put in pink, is our not the conduction part. This is the part where actual gas exchange will happen. Okay. If we talk about embryology, lung development has 5 stages. Don't think this is a very complicated slide. How we'll remember? It's very easy. Very easy to remember. What are the stages of lung development? At 4 weeks, we know from the cranial part of the foregut, a respiratory diverticulum arises. And this respiratory diverticulum is going to give rise to our lungs. Okay. In the beginning, this foregut is connected to this respiratory diverticulum. So obviously there is a fistula. But as the gestational age advances, this fistula closes by a septum known as the tracheoesophageal septum. Just in case, if the trachea, the septum is not formed, what is going to happen? We will have a tracheoesophageal fistula. So you should remember that if you see a case of tracheoesophageal fistula while doing your scans, anomaly scan or both scans, the defect or the insult has happened at what stage? In the stage 1. That is the embryonic stage of development of the fetal lung. Okay. Now, this lung bud, after it will divide into 2 primary bronchi, and then it is going to invade the pericardio-peritoneal canal. Okay, it will invade it. Now this will divide into secondary and tertiary bronchi. The part of the pleura which remain attached to the lung, we all know it's known as the visceral pleura, and the part surrounding the pleural cavity is the parietal pleura. The visceral pleura arises from the splanchnic mesoderm, and the parietal pleura arises from the somatic mesoderm. This primary bronchi, when it divides into secondary bronchi, we know that on the left side there are 2 secondary bronchi, and on the right there are 3. What does it signify? It signifies number of lobes. So it is also known as the lobular branch. The right lung has 3 lobes and the left lung has 2 lobes. So any defect in the development of these secondary bronchi can lead to lobulation defect. Okay. And this secondary bronchi is going to give rise to tertiary bronchi. These tertiary bronchi are nearly 10 on both sides. These are segmental bronchi. This is lobular bronchi. This is segmental bronchi. There are 10 bronchopulmonary segments in each of the lungs. Okay. Till here, formation, let me revise from here itself. Formation of respiratory diverticulum, formation of the lung bud, then closure of the tracheoesophageal septum, formation of the pleural cavity, and division of primary, secondary, and tertiary bronchi. All this comes in the embryonic stage. That is the stage 1 of lung development. The next stage is pseudoglandular stage. Why this name? Now this tertiary bronchi divides into bronchioles, which further divides into terminal bronchiole. At this stage, the splanchnic mesoderm, which is surrounding the developing respiratory tract, start developing blood vessels, and it is lined by cuboidal layer of epithelial cells. So what happens? It looks like a gland. Therefore, it is known as pseudoglandular stage. When we talk about what week when this happens, is basically happens between week 6 to 16. If you read different books, some will say 5 to 17, 6 to 15. For the ease of our remembrance, how I have divided it, most of the book will uh, write this only. It is 6 to 16 weeks. Okay. So the stage 2 is the pseudoglandular stage, which is between week 6 to 16. Now, this terminal bronchiole will give rise to respiratory bronchioles, which will further give rise to alveolar duct. And how does a duct look like? A duct look like a canal. So now this stage is known as the canalicular stage. It is stage 3. Okay. And when this is seen, it happens between week 16 to week 26. After this, after the formation of alveolar duct, we all know the alveolar sac is formed. Therefore, stage 4 is known as the saccular stage. It happens from 26 weeks and up till birth. What happens in this? The alveolar sac is formed. It is lined by two types of pneumocyte, type 1 shown in blue color and type 2 which is shown here in orange color. These type 1 pneumocytes are very thin cell. Their function is respiratory gas exchange, okay? And these type 2 pneumocytes are basically responsible for secretion of surfactant. What surfactant does? It lines the alveoli and reduces the surface tension and prevents the alveoli from collapsing. It doesn't end here. The last stage is the alveolar stage. What does it signify? That after birth, also our lung keeps developing. We need millions and trillions of alveoli. Till 8 years of our birth, after birth, alveoli keep proliferating. So the last stage is the alveolar stage. Okay. To conclude, we have 5 stages. Stage 1 is embryonic stage, which is seen between week 4 to week 6. From week 6, we enter the second stage, which is the pseudoglandular stage. From pseudoglandular stage, from 16 to 26 weeks, we have canalicular stage, where it looks like a canal, where alveolar duct is seen. From 26 weeks, the alveolar sac is formed. The alveolar sac, so therefore, this stage is known as saccular stage. Okay. Now, what happens at birth? We know during intrauterine life, our lungs are not functional because the pulmonary vascular resistance is very high. All the oxygenation part is done by the placenta. And we have conduit like foramen ovale and ductus arteriosus are the shunts, which helps in passing the oxygenated blood to the fetus. But as the baby cries after birth, the lungs expand. The phospholipid or the surfactant which is secreted lines the alveoli. It decreases the surface tension. It decreases the pulmonary vascular resistance. Therefore, lungs expand. And now the type 1 pneumocytes start acting and the gas exchange starts happening. Slowly, our shunts will close, okay, over the period of time. So, in this physiology and the anatomy of lung development, where does the role of steroid comes? We are giving steroid for lung maturity. So in normal embryology also, they at some stage, steroid will be secreted in a body which will be coming and helping the development of lung. So from the canalicular stage, actually, we start seeing role of glucocorticoids. That is, from here we can see that steroid is coming into action. And when is the canalicular stage starting? It is from the 16 weeks. Okay. This is a very compact type table which I have made for all of you. So imagine if the defect or the insult happens in the embryonic stage, what will happen? The lung low bud will not form from the respiratory diverticulum. There will be pulmonary agenesis. If the secondary bronchi are not formed, there'll be lobulation defect. If the tracheoesophageal fistula doesn't close, the septum doesn't form, we will have a tracheoesophageal fistula. So this becomes very easy if you understand the embryology, what defect will happen, which stage the insult has happened, you can easily make it out. For example, if we look at pseudoglandular stage, in this stage, what was happening? The terminal bronchioles was being formed. So the conducting path will be defective. So what it can lead to? It can lead to sequestration, it can lead to congenital diaphragmatic hernia, and it can lead to cystic congenital adenomatous malformation, also known as CPAM. When the defect is in the canalicular stage, what happens in a canalicular stage? What is being formed? The alveolar ducts. So there will be pulmonary hypoplasia. In saccular stage, the phospholipid or the surfactant is being secreted. If it is deficient, the baby can have pulmonary hypertension. And the last alveolar stage, that also signifies that also is mainly focusing on the number of alveoli. So if it is less, the patient or the fetus is prone to develop pulmonary hypertension in future. In antenatally, what the steroid does, we understood, okay, from 16 to 26 weeks, in normal embryology, glucocorticoid is coming into action and helping us in lung maturity. Normally, the steroids causes thinning of the alveolar capillary membrane, which will help in gas exchange. It increases the surfactant, it increases the antioxidant enzymes, it increases the compliance. So basically, it is helping us in all kinds of respiratory efforts. It also increases surfactant response to the treatment, and it also decreases the surfactant inactivation. Clinically, it decreases the incidence of respiratory distress syndrome by 34%, decreases the incidence of interventricular hemorrhage by 46%, it decreases the incidence of necrotizing enterocolitis by 54%, and overall decrease in mortality is by 31%. Steroid, whenever we use, we all know it's a double-edged sword. Long-term steroids complication, we know. But here we are giving steroid only for short term, that is 48 hours. But still it has few implications. In the fetus, when you're giving steroid, tell the mother, she can have reduced body movement, fetal movements. She can have a baseline increase in fetal heart rate. Okay. Mother's total leukocyte count can go high. Even the mother will have transient hyperglycemia for 5 to 7 days, which will settle afterwards. And if the mother is on other drugs like tocolytic or she is having infection, then she becomes prone to pulmonary edema also. So what we know is that in preterm, when we give steroid, it is going to decrease the risk of respiratory distress syndrome. This was first proven by Professor Lignin and Harvey, and the study was done in sheep, and it was seen that later it was conducted in human, and it was seen that prenatal corticosteroid decreases the respiratory distress syndrome in babies. Now, the question arises is, which steroid to choose? Why we are giving dexamethasone or betamethasone? We are not giving prednisolone. Why? There should be some reason. The reason is their metabolism. Fluorinated steroids like dexa and betamethasone are not metabolized by 11-hydroxysteroid dehydrogenase enzyme. Therefore, a large amount of the hormone is transferred from the placenta to the fetus. But prednisolone hydrocort, which we use in autoimmune condition, is usually metabolized by this enzyme. Therefore, it's not transferred to the fetus and it will not help in lung maturity. Hence, fluorinated steroids are preferred for lung maturity. If we compare which is better, dexamethasone or betamethasone, overall both are same, but in India mostly dexamethasone is preferred because we don't have that acetate phosphate mix which should be given, or usually we get a phosphate or a acetate. Combination is very difficult to find. Okay, and only few meta-analyses have shown that there is some little increased risk of chorioamnionitis if we give dexamethasone. But practically speaking, this is about studies. Dexamethasone doesn't increase the risk of chorioamnionitis. Okay. Talking about the dose of steroid, the dose which we give is 24 milligram and it is divided doses. We give Dexa is given 6 milligram, 12 hourly, 4 doses, 12 hours apart, and Betamethasone is given 12 milligram, 2 doses, 12 hours apart. Timing of steroid. Steroid should only be given when you are anticipating a preterm delivery. I'm very specific. When you are anticipating a preterm delivery. First question is, how will you anticipate? Okay. See now, okay. Just by if patient is in labor, we know, okay, she is already in labor, she's in active labor, she's going to deliver, we know, okay, but how to predict? There should be some tool which can help us in predicting. You all can download Quip app. It's proven by King's College London. It's a very friendly app you can have in your mobile phone. And even if you don't put fibronectin, if patient comes with symptoms of preterm labor, put in the data, you will get a number and that number will be specifics. Any number above 5%. If you get a risk of preterm labor more than 5%, you have to actually give steroid. Okay? Don't give steroid like that only. Be very methodical for using this. You will understand why I'm stressing on this point so much. Okay? So you should give steroid when you're anticipating delivery in next 1 week. Okay? And sometimes if you get a patient, she's already in labor, she's 4 to 5 centimeter dilated, you know she'll deliver in next 6 hours. Should you give steroid? Yeah, at least give her first dose. It's going to benefit if she is preterm. Be mindful if she is preterm and if all her criteria are full, we are fulfilling the criteria, we can give at least single dose of steroid. Even though we may not be able to we may not be able to complete the doses. Okay. So what we have studied and what we know is preterm gives steroids. So till what gestation? Now all the guidelines from 2022, everything has changed. They have become very specific. Every guideline is saying only up to 34 weeks you can give steroids. Only RCOG is recommending up to 34 plus 6 weeks. Why this change has happened? Basically, see, a fetus has a tendency to live in a hypocortisolic milieu, means it wants a low cortisol environment. For example, if the mother is in stress and mother cortisol hormones start rising, what will happen? The placenta will start secreting 11 beta steroid hydroxydehydrogenase enzyme. What it will do, it will metabolize all the steroids. So fetus will not get the steroid which is increased. Okay. But when we are giving exogenous steroid, it will be transferred and the fetus will be exposed to supraphysiological level of steroid. Why after 34 week only this we are so specific? Because after 34 week, brain development is very rapid. At this time, if we expose the fetal brain to such high level of steroids, if it's not indicated, it can cause steroid-induced neuronal death, which will disrupt gray and white matter development. Okay. So now let's discuss about antenatal steroid and special circumstances like pre-viable birth. Just now we understood that in canalicular stage from 16 weeks, the role of glucocorticoid in our body, in normal human body, starts acting which helps in development of the lungs. But we don't give steroids at 16 weeks. Why? Because though lung maturity, it can help in lung maturity. Physiologically, glucocorticoid is acting in development of lungs. But for the baby to survive outside, only lung maturity is not enough. In India, 28 weeks is still a very good gestational age for preterm delivery. And it depends, actually varies from center to center. For my place, 26 weeks is the cutoff. Any fetus above 26, we go full in, we don't wait that it's very preterm and let it get aborted. No. The smallest baby which I have seen surviving in my NICU setup is 626 gram. So it depends on the center, at what place you're working and what kind of facilities you have. According to ACOG, they say from 23 weeks onwards, you can start giving steroid. 22 to 23 is very dilemma. Above 24, they are actually recommending to give steroids. Okay. Below 21, now at present, ACOG also is not recommending to give below 21 week. So for simplicity, we should remember that above 23 weeks, we can give steroids. If the couple, if the pregnancy is very precious, they are very adamant that they want to continue the pregnancy, they are very keen on the baby, at least we can give a chance to the baby. Or if you are in such a setup where this is not possible, kindly transfer the patient in utero, the fetus should be in utero, and transfer it to such center where they can actually help the baby. We can help the baby in surviving. Okay. Now, if we talk about late preterm, this was about pre-viable births. Now, if we talk about late preterm, till 35, 34 weeks, all guidelines are recommending that we can give steroids. And we have already discussed why after 35 weeks they are saying not to give steroids. Okay, that is because it will cause steroid-induced neuronal death. Some risk of neonatal hypoglycemia also is seen. Okay. Talking about term pregnancy, when I was actually doing PG at that time, if any previous cesarean or previous to cesarean, she was posted for elective cesarean, my consultant would tell me, okay, she is less than 39 weeks for elective cesarean, give off steroid. That was the teaching when I was a PG student. But now everything is changed. They say, don't give steroid, it's harmful. You can't give steroid. In late preterm, if somehow the patient, somebody told the patient's very keen, they will answer, they will ask you questions. Madam told to give steroid, you are not giving steroid, that will help. Now people have ChatGPT, they have Google, they will ask you 10,000 questions. Be ready, tell them, we can give steroid, no problem. But you should know that at this gestation, the steroid can cause neuronal death, which can hamper the baby's development later. Usually, what is seen, I'll tell you in later slides also I've written, these babies who are exposed to unnecessary steroid usually have low performance in school. That people will think other reasons, but this is one of the major reason of having a low performance in schools. Okay. So this elective cesarean we already discussed. All the studies have concluded, I'm telling you about conclusion only, that there is increase of neuromotor, neurocognitive and neurosensory impairment if we compare children up to 5 years of age who were born at term, who have received steroids, compared to children who are born at term and not received steroids. Okay, so this is a slide from Green Top Guideline 2022 RCOG, which says that school educational attainment may be reduced from 9 to 18%. It may help in respiratory morbidity, it may help, but this also we have to keep in mind. It is not like steroids are very safe, give no harm, only 4 doses. No, it is. We have to keep that in mind. In preterm pre-labor rupture of membrane, if the patient doesn't have sepsis and patient is preterm, antenatal corticosteroid is recommended. For multiple pregnancy, if you talk about, dose is same. It is not like there are 2 fetuses or 3 fetuses, so dose of steroid should increase. No. The dose of steroids is same, 24 milligram. And talking about repeat doses, sometimes we might have seen that patient came at 26 weeks or 28 weeks. She was having pain. She was admitted somewhere. Steroid was given. Patient didn't deliver, and then patient pain subsided. She went back home. Now again at 31 or 32 weeks, again she is having pain. Now what you will do? This time she is in labor. Now she is 2 centimeter dilated. Now the question arises, she's already received steroid. What is the answer? The answer is you can give single repeat dose of steroid if it is more than 7 days have passed from the last dose of steroid. You cannot give multiple doses, but at least 1 dose. And that time also be cautious. See that. What is the risk? I told you, you can download Quip app. Download in your mobile and it will become your friend. Very easy. And everything you will have in percentages, like risk of preterm labor before 34 weeks, 2%. Risk of preterm labor before 37 weeks, 3%. Like that it will come. So you can tell the patient, oh, only your chance of delivery is only 2%, 98%, you are not going to deliver. Patient will be also, you will be confident, patient will be confident that, okay, my chances of delivery is low. Then only if you know the percentage, then only you can decide whether I should give steroid or I should not give steroid. So this you keep in mind, okay? So if you have to give second time any patient, first calculate the risk. If high risk is there, you can think of giving repeat dose of steroid. And the most common thing which we see in practice, pain. Acha, steroid de do. Just give us steroid. No, please. Next time, if you see anybody giving steroid, please tell them, Madam, Sir, steroid is harmful. We have to be cautious. Okay? Never give steroid just in case. This is the main take home message which I want everybody to be clear. Steroid is not a paracetamol which you can give to everybody. Okay? So let me conclude. Antenatal corticosteroid is very good if it is given in a proper indicated condition. That is, before 34 weeks, any patient who is in labor or has symptoms of labor and our predictive test is telling that the risk is high. Quip app showing any risk more than 5% is considered a high risk. Please give steroid to the patient. While giving steroid, keep in mind if the patient is pregestational or a gestational diabetes, you have to monitor the sugar because patient sugar is going to increase for next 5 to 7 days. Okay, if patient is on insulin, let me tell you this also, for first 2 days 10 to 20% insulin demand will increase. On day 3 to day 5, 40% increase in sugar level will be seen, so you will need more insulin. By day 6 7, the sugar level will start decreasing and patient will return back to her normal doses of insulin. So during that time, that 1 week, you may need extra doses of insulin. And what we use is a sliding scale of insulin. We adjust the insulin dose based on a sugar. Okay. We already discussed that Dexa and Betamethasone are equally competent. You can use either based on availability. Maximum benefit of antenatal corticosteroid is seen if we can complete all the 4 doses and we get a 24-hour period after the steroid, then that will give much better action than if we are not able to complete the doses. For late preterm, if somebody is insisting for steroid, please sit with them, be mindful, tell them these are the benefits. Yes, steroid can decrease the respiratory morbidity for the fetus, but these are the harm which can happen to the fetus. We discussed, you can give a number also, that in 9 to 18% cases, there can be some delay in performance in school and the baby can have hypoglycemia because of the steroid. For term cesarean section, please don't give steroids. Multiple pregnancy, the dose is same. Steroid just in case is a big no. And for pre-gestational diabetes in late preterm, FICU has actually put steroid as a contraindication because it's going to worsen neonatal hypoglycemia, and neonatal hypoglycemia can be risky. Okay. So these were my slides. And this was all about steroid. Let me revise for you what we discussed. We discussed about the embryology. There are 5 stages of lung development: embryonic, pseudoglandular, canalicular, saccular, and alveolar. Okay. In this stage, how is the stage divided week-wise? Up to 4 to 6 weeks is embryonic. 6 to 16 is, I want you all to be very attentive, okay? 6 to 16 weeks is what? Can anybody answer in the chat box? I'm waiting for your response.
Please answer if anyone is there.
If anybody is there, please let me make this session interactive. Nobody's going to judge. It's just, I want to see how much you all understood. Okay, let me revise. Stage 1 is embryonic stage. In embryonic stage, what is happening? The primary, secondary, and the tertiary bronchioles formation is happening. After that, what is happening? We enter pseudoglandular stage, which is between 6 to 16 weeks, in which the whole of the conducting part up to the terminal bronchioles are forming. From 16 to 26 weeks is the canalicular stage, where the canals is being formed. Okay. In this stage only, the steroid comes in action. From 26 weeks to birth is the saccular stage, where the alveolar sac is being formed. And from birth till 8 years of life is the alveolar stage, where alveoli are proliferating. After this, we discuss what kind of steroid should be used, fluorinated or non-fluorinated. Fluorinated steroid is not metabolized by 11 beta hydroxysteroid dehydrogenase enzyme. So that is transferred to the fetus. Hence, we prefer fluorinated steroid for lung maturity. Example of fluorinated steroid, Dexamethasone and Betamethasone. After that, we discuss when it should be given, the dose 24 milligram, when we are anticipating preterm labor. Okay. Then we discussed till what gestational age. It was up to 34 weeks. Then after that, we discussed why till 34 weeks, because after 34 weeks, steroid-induced neuronal death risk increases. After that, we discussed why when we should give earliest, about pre-viable birth. For pre-viable, we discuss from 23 weeks, we can offer steroid based on the institute or the place where you are working. Okay. In elective term cesarean, we should not give. For late preterm, tell them about the risk and the benefits. Then in multiple pregnancy, the dose of the steroid is same. Steroid should not be given just in case. And for PPROM, if patient is not in sepsis, give steroids. Okay, for pre-gestational diabetes, give steroid with sugar monitoring. So these are few things about steroid. I hope it was clear. Any questions? I'll be happy to answer.
Please unmute yourself and ask questions.
Any question will be okay. Don't worry. Don't think that, okay, this question, if anything, just ask. Be free. See, later, when we have our classes, once you have understood these stages, no, okay, what is tracheoesophageal fistula or CPAM or CCAM or CDH, I'll show you ultrasound images when I'll be showing you, then you will understand. And having this embryology in mind only, you can get those things in your mind. Recently, I had a congenital diaphragmatic hernia case, and she came to me at 34 weeks. So diagnosis was made at 34 weeks, which should have been diagnosed very early. If you remember, we just now discussed when we can, at canalicular stage itself, we can diagnose a congenital diaphragmatic hernia.
Okay, ma'am. Thank you so much.
Okay.
Thank you
Thank
for
you.
the class, ma'am. Thank you, ma'am. Thank you so much, ma'am.
Thank you so much. Thank you.
Have a great day. Thank you, doctors, for all whoever joined the class. Thank you so much. Good evening, all of you.